Welcome, everyone. Welcome to our guests who've joined us online. I'm Pamela Schaff, and I'm the director of Keck School of Medicine's Humanities, Ethics, Art, and Law, or HEAL program, and director of the Master of Science in Narrative Medicine program. The Lunch and Learn series is part of HEAL's mission to invite scholars in the humanities, arts, and social sciences to share work that informs our collective understanding of the health of individuals, communities, and societies. We're so excited today to collaborate with Cedars-Sinai's program in the history of medicine to bring you today's presentation, and a special thank you to Cedars for making CME credit available, as you see on the slide. I'd like to introduce Gideon Manning, who is Associate Professor of History of Medicine and Director of the Program in the History of Medicine at Cedars-Sinai.
Thank you for the applause in the room. So thank you, Pam. Thank you to our speaker, to Paige for all her help, and everyone attending here in person and online. As Pam said, my name is Gideon Manning, and I'm the director of the Cedars-Sinai program in the history of medicine, a research and educational laboratory within the Center for Arts and Medicine at the Cedars-Sinai Medical Center. Prior to my role at Cedars, while I was still a professor at Caltech, I spent a research year as a medical student at the Keck USC School of Medicine. I haven't been back since. I had a sort of PSD experience as I was driving past the parking lot. But it's a homecoming of sorts, and I'm very happy to be here. But really, and I believe I speak for Pam as well, today's event is the beginning of something more. For several years now, the health humanities, which includes literature, the arts, ethics, gender studies, and history, has been enjoying a renaissance in the United States and around the world, marked, in the United States at least, by an eightfold growth in health humanities degree programs among undergraduates since the year 2000, and now greater than 80% of medical schools offering required health humanities courses and electives. Nowhere does the future of health humanities look brighter than here in Los Angeles County. The HEAL program at USC and the program in the history of medicine at Cedars-Sinai are the established anchors of a growing community of scholars and educators that now includes colleagues like the incomparable Ericka Johnson at UCLA, leading cultural institutions like the Getty Center and on the west side, and the Huntington Library, Museum, and Gardens on the east, and societies like the Southern California Society for the History of Medicine, which sponsors yearly speaking events at the Huntington Library, and soon, hopefully, at the Getty as well. In the future, you should expect to see more and more joint efforts among this list of individuals and institutions, all of whom are doing their part individually, and now I'm happy to say, starting today, collectively, to make Los Angeles County and Southern California one of the world's leading destinations for teaching and research in the health humanities. I would especially highlight the coming Pacific Standard Time exhibitions organized by the Getty that will open in 2024 with a theme tied to medicine and art. I could not be happier to be a part of all this, or for Cedars to be partnering with Pam and USC today. I now wish to hand control back to Pam to introduce our distinguished speaker. Thank you.
So it is my real pleasure to introduce Ericka Johnson today, who is here from Sweden. She's a professor of gender and society at Linköping University and a member of the Center for Medical Humanities and Bioethics at Linköping. She's a member of the Royal Swedish Academy of Science and the author of A Cultural Biography of the Prostate, published by MIT Press in 2021. Dr. Johnson's interdisciplinary research combines the best of social studies of science, medical sociology, and feminist science studies. Her current work examines medical technologies and the multiple ways in which artifacts express and highlight the cultural values that shape our lives. Dr. Johnson will speak to us today for about 35 or 40 minutes, and then we hope to have time for questions. Online guests, please use the Q&A function to submit your questions, and we'll do our best to answer as many as we can. And following today's talk, Dr. Johnson will be available just outside to sign books. So with that, I will turn it over to Dr. Johnson. Thank you.
And I'm just going to see, you guys can hear me way in the back? Great, thank you. Right, thank you very much for coming, and I hope the lunch is good, and I hope that what I'm going to talk about and the slides doesn't make your appetite turn, but I'm guessing you're medical students, so that's probably okay. The book up there is where I and many of my colleagues who have done a fairly large and long study about the prostate have put together our results. I'm going to talk about first what our interdisciplinary team was and what kind of problems and opportunities that brought with us when we wanted to study the prostate. Then I'm going to talk a bit about our results in different ways. And then at the end, I'm going to make some connections to where I think our results, and in particular the results that are specific to the medical humanities, could help us as a collective work towards providing better prostate care. So bear with me as I see if we can move this. Right. I promised I would put up a slide from our center as well. I am a professor of gender and society. I'm at an interdisciplinary department at Linköping University in Sweden. But we also have there in Linköping a Center for Medical Humanities and Bioethics that is across all of the different faculties, where we let or encourage or facilitate conversations between people who work in the medical faculty, people who work in the philosophical faculty, but also the technical faculty at our university, and try to bring us together on a monthly basis to see what sort of questions we have and concerns that we have where we could be informing each other on them. There are about 70 of us that have come under this center's umbrella in the last few years since we started it up. And not all of us are super active. Some of us are very active. But all of us have, in one form or another, an interest in, and usually a research interest in, something that is taking medical questions beyond the biomedical and trying to see how humanities and social science theories can integrate that. Some of these are single projects with one researcher in them. Some of them are larger projects with 8 to 10 researchers in them. We have just recently gotten a grant from the Swedish Science Foundation to do a 6-year project with, I think there are 10 of us, looking at how long COVID or long haul COVID is being produced and understood in a very interdisciplinary way. So we have people working in neurosciences, rehabilitation medicine, but also the humanities and philosophy all working together around these questions. So it's a very interdisciplinary center. And it was because of that I was able to come into contact with the people here. And I've been really, really grateful, one, for the conversations I have with my colleagues at Linköping at this center, but also for the fact that it's been a door opening up to other researchers and research groups here and around the world. So thank you. Now, you may not be wondering why I would spend 10 years of my life thinking about the prostate, but my husband has definitely wondered about it. And I thought I would just give you a bit of brief background onto why. About 15 years ago, I was working on a research project in Sweden that was looking at the way the Swedish masculinities and understandings of what it meant to be a Swedish man were affected by the introduction of Viagra. So this was like hot back then, but this was quite a while ago. And what I kept finding as I was looking through the legal material about whether or not Viagra should be subsidized in Sweden, looking at the medical conversations about whether or not we should be prescribing it to Swedish men and which men, and what type of advertising and marketing was being used to produce a consumer group for this pharmaceutical. In all of these conversations in the Swedish context, I continuously encountered the prostate. And as many of you probably already know, Viagra is one of a bouquet of pharmaceuticals that are often prescribed to people who have had their prostate removed and still want to produce an erection. So it's not entirely surprising that it was part of this conversation already back then. However, what did amaze me, or what tickled the medical sociologist in my gut, was that there seemed to be a really broad understanding of what this prostate was and what problems it would cause. And I would encounter conversations in medical literature, both in Swedish and English, which would use phrases like the prostate, a constant torment, or it's probably the prostate that's haunting him, when describing a patient who had presented with some sort of diffuse condition that no one was quite sure what it was. And when I heard that, I thought, what is this amazing gland that can haunt the person who has it? How are we producing knowledge, especially biomedical knowledge, that would then be treated with a pharmaceutical from a gland that sits there and takes on some sort of ghost identity and haunts the person who has it? So all of that turned into, for me, questions about what is the prostate in a very critical studies type of way, where is a verb that we just have to unpack, and there will be multiple is's in these sentences. And I went around thinking about this and wondering how I could find an answer, and reading the medical literature and getting more and more confused, and dreaming about a huge interdisciplinary project that would approach this question from many different directions. And then the Swedish Science Council came out with a really random odd call that let this type of question be asked. And I will not put, in Swedish we would call that put it under the chair, I will not hide the fact that I am completely convinced that a grant application that was going to look at the aging male prostate appealed to many of the bodies who were sitting on the grant evaluation committee. So I don't think it was my genius grant writing skills that got the grant, but I did get the grant, which was nice, because then I was able to put together my dream team of researchers who would help me work on this project. We pulled in 18 million from the Swedish Research Council, which is about $1.8 million, and allowed me to get people from the social sciences and the humanities together for a period of 7 years. I got 9 researchers. Here you see 7 of them. I got historians like Maria Björkman and a colleague of hers, Elin Björk. I got an anthropologist like Jenny Gleisner and another colleague who did anthropological studies, both of examinations of prostates, but also followed the blood in a very STS way from the body into the lab and through the lab as we tested it for PSA. I had a sociologist, Oscar Maldonado, who was looking at the way risk was produced for patients and the risk of not getting the right results for PSA tests, and had compared this to how cervical cancer testing is also done in other countries. And then also looked at the way this was happening in Colombia. I had a sexologist who was working at a urology clinic who was concerned that there were not enough studies being done about how men who don't identify as heterosexual or cis male were not visible at all in the material for how sexologists should deal with people who have had prostate issues. So she paired up with Hjalmar Bruggeman, who is a medical ethicist and sociologist that I hired to work together on designing a study that would look at different types of patients and see what types of sexual rehabilitation they would benefit from. And I had an organizational studies person, Alma Persson, who looked at the way urology as a field has developed over time and how the prostate becomes an object of concern for urology as well. Anyways, as you can see, there are no medical doctors here in this study, which is a little weird. I get it, that we were doing a whole study on the prostate without any medical doctors, but the point was, I wanted us to look at how the prostate was produced in different conversations. And I could read about how the prostate was being produced by medical doctors as an object of knowledge there. I wanted to see it through different types of methods and theoretical lenses. And so this is the team I put together. We started working. I thought, well, we're interdisciplinary, but we are largely all social sciences and humanities. There should not be too much of a problem of us working together on this project. And actually, I knew most of these people beforehand, and I liked them, and I was like, I drank coffee with them at the office. I thought this will work really well. And it worked pretty well, but it was not problem-free. And I think this was one of the big lessons I learned, was that there were fundamental different epistemological conversations that we were having in our own fields that we then, when we came together to figure out how to put them together into one project, really dictated what we thought was appropriate material and appropriate knowledge. So one of these challenges, of course, was a conversation about what is data. How are we going to work together to produce knowledge about the prostate? I should probably tell you, the title of the study that we were all working together, the grant study, was A Constant Torment, tracing the discursive contours of the aging prostate. And I thought that would be like a way to umbrella all of us under it. It sort of did, but it turned out that when we started to trace those discursive contours, we had different understandings of what discourse was. Is it material discursive? Is it just text material? Is it, interviews? Does that become a discourse? We had different understandings about where we would find material. Is it going to be in the archive? Is it going to be in the phone after I've done an interview with somebody? Is it going to be some sort of grounded theory collection of photographs and notes that people have made during their fieldwork, ethnographic fieldwork? And once we have all of this data, and even if we could agree on what was appropriate data, what were we going to be allowed to do with it? Who owned it? Of course, there were like ethics committees that have one understanding of that, and we filed it and got approval for all that. And we, of course, respect the ethics committee understandings of what to do with data. But it was more than that, really, as well. When we have data, some of us thought that we then had data. That was the result. Some of us thought that the data that we had was then an input into a conversation that would be colored by our theoretical lenses. Some of us thought we could share data back and forth. Some of us thought that, well, this was my data. All of these conversations turned out to be much more confusing and difficult to navigate than we thought. And I won't even go into the conversations we had about how is this, because they were mostly junior researchers, how is this study going to actually be beneficial to me in my career trajectory, and where can I publish so that I can get a job as a historian afterwards, or as an anthropologist with all this interdisciplinary stuff that I've been doing. Anyways, that's sort of the background to the study. We did nonetheless get past all these conversations and start to think about the prostate itself. But then, of course, it turned out that what the prostate itself was is really a fraught conversation. Here, I have a picture of the prostate from probably the end of the 1700s. This is a picture of a wax relief that's stored in the basement of the Zurich Medical History Library and Archive. And I had asked, I sent off a bunch of emails early on in the project to a bunch of archives and medical libraries around Europe, trying to figure out where we could find the earliest representation of the prostate. This was one of the earliest ones that we could find. And I went down there, and the archivist, who was extremely happy suddenly to have somebody interested in looking at their archives, I got the feeling that that didn't happen so often, was more than thrilled to bring me deep down into this like hollowed out cave area in the basement of their library building, where they had the temperature and the humidity really controlled. They had all sorts of artifacts stored there, and she cranked open one of the large archive bookshelf things and pulled out this and 3 other wax reliefs and said that this is probably the oldest relief that they have from representing the prostate. And then she let me take the photographs of it with my iPhone and said, follow me, and brought me to the other side of the archive hall there, where she opened 2 doors, 2 metal doors, into a cabinet that had boxes upon boxes upon boxes with little labels for different body parts in them. And she pulled out one, this eye one. There was one with like babies, babies, arms, feet, heads, eyes, ears. She pulled out this one. This was the eye one, opened it up, let me look into it. This is what was inside of it. And she said that these eyes, along with all of the other eye votives in that box, had been collected through the centuries in the small side chapels of larger churches in the valleys of Switzerland, in amongst the mountains there. When people would, especially earlier, but even today, have a problem with their body, they would find a person or themselves, make some sort of votive of that part of the body, bring it to the Catholic Church, light a candle, say a prayer, put in a donation, and leave that votive in a particular place in the side chapel of the larger church. And then the churches themselves collect them and have donated them to the Medical History Museum and Archive there in Zurich. These wax eyes are made probably in the early 1700s and are made most likely by a relative of the same person who made the prostate wax relief here at the end of the 1700s. And what she said was that this family, it's a well-known family, has for centuries been making wax votives for people to leave at the cathedrals in Zurich, in Switzerland. But then sometime in the middle of the 1700s, they realized that it was also now going to be a lucrative market opening up with the professionalization of medical care, with doctors who needed to have some way of demonstrating to their customers that they know what's going on in the body and that they can articulate their expertise in a visual way at their offices and clinics. So they started making wax reliefs of the bodies based on anatomy pictures in books rather than just on the body and how they would put it in a church's side chapel. There are 2 points to this that I want to bring up, One is that I think there's a lot to be said about the way we institutionalize medicine in this photograph and where we institutionalize our needs for health. Now we tend to think of it as health is something that you come to a doctor for. Health is something that you deal with through the biomedical campaign. But it has not always been that way. And we have other social institutions that have approached us, that we have used to approach the health that we want to achieve, the church being one of them. The other one is that I think we can see in this photograph how the knowledge of our bodies has a trajectory, or has a genealogy, as we like to say. And then the technologies for representing that knowledge also have trajectories, and they're not seldom very connected. They are often very connected. That these trajectories of knowledge-making practices seep in and out of different social institutions. And here we see how the wax representations of the body have different fields that they're working in different areas. Also of interest, there was no box with the prostate of votives collected from the churches. But we had known about the prostate even before this wax relief was made. So the wax relief on the side was made at the end of the 1700s. Here in the middle is Vesalius's sketch from the anatomy book from 1543, which is the first place in Western medicine where we see the prostate actually sketched, though it's not named. It's not labeled or articulated as such, but it's sketched and is part of there. Probably the first place is in some loose folios that he had done in 1538, but it was collected together in this book in 1543. Here, just stolen off the internet, is a picture from Leonardo da Vinci's work on the anatomy. A couple decades earlier, nothing there with the prostate. It isn't sketched at all. So, I don't know, if you're thinking European understandings of the body, the prostate appears in 1543 or 1538. But it doesn't get named until the very end of the 1500s. And then by the 1600s, there's the word prostatea is being used for it quite frequently. In the plural, if you're thinking you're Latin. And in the plural, because it wasn't really clear if that gland was one gland or two glands. I would say that our language for it today in English doesn't make that clear either. We have the single, the prostate. We use it that way, but it is actually made up of many small little glands. But there was a long debate for a couple of centuries about whether or not it should be two or one, because it is a symmetric gland as such with two nodes. And then by the end of the 1700s, it was being called the prostate in English, and by the 1800s, it was definitely a singular. So I mentioned that I had a couple of historians working with me. All of these like basic facts about the history of the prostate, they weren't very interested in that. But what they were interested in was going into the archives and seeing how the prostate was being talked about or used or treated in very specific contexts and at very specific times. One of them, Elin Björk, did her PhD on a really interesting, though not very successful, attempt to cure both benign prostate hyperplasia and also prostatitis, depending on how you want to go backwards and reapply our terms to what was being treated then. But a treatment for an enlarged prostate that was popular at the end of the 1870s and into the 1880s, and then was dropped in Europe. Didn't get used very much in the US either, and that was castration. It was not very popular with the patients, which is one of the reasons why it was dropped. But it also turned out not to work particularly well, which is another reason why it was dropped. However, there's something really interesting about this idea that they would think that we could use castration to treat an enlarged prostate, and that is that this was based on an existing practice at the time of removing the uterus and sometimes the ovaries from women to treat problems, often diffuse, sometimes related to urination, though often more related to what was then termed hysteria in women. And so because they were removing parts of the internal anatomy for women at the time to treat this type of problem, the doctors thought, well, it looks as if the prostate is sort of related to the uterus. Why don't we just remove the prostate and see what happens? Or why don't we castrate the men to see what happens? Of course, a person could have tried to remove the prostate. There were surgical attempts to try to do this, but it was really dangerous and had a huge mortality rate, I think that you would be calling it, men dying on the operating table or shortly afterwards because of infection. So trying to remove the testicles seemed to be a good option. Like I said, it didn't really work, but it is an interesting case of where knowledge about what was thought of as the female body then was used to directly impact how they thought and imagined the male body. And this is something that we in the history, gendered history of medicine, often see the opposite of, where the female body is thought to be just a subcategory of the human body, and all the knowledge about the human body is based on the male. Here we saw something exactly the opposite going on, which was pretty fun, I thought. In addition to the castration, there were a couple other treatments that they looked at from the same time period. There was the use of a sonde, a very sharp object, being poked up through the urethra to try to create some sort of space for the urine to flow through. As you can hear, lots of these problems tend to present as a difficulty with urination. There was the operations that we talked about, but these were incredibly dangerous and not necessarily very successful even when the patient lived, didn't get infection. And then there was the attempted use of electricity as a therapy, where there were different ways of doing it, but mostly an electrical node was put up through the anus and placed right at the prostate, and then another one was put onto the testicles, and then electricity was shot through them to try to reduce the size of the prostate. Interestingly, in the archival material around this one, it is mentioned that the doctor should stop the procedure at the first sign of discomfort from the patient. I'm kind of guessing that there would be discomfort the moment the machine is brought into the clinical room. But yeah, it didn't really take off, actually, either. Now, here is one of the conversations that we've had in our discussions a lot. What do you do with historical material like this? And for me, who's not a historian, I think we misuse it immediately and try to see what sort of parallels we can draw to how we're talking about treatments today. Of course, my historian friends were not really happy about that, but I thought there were actually some really interesting parallels about the conversations that we do have about the prostate and its treatments today. And these are conversations about the side effects of the treatments. There are many, many fewer men dying from prostate treatments today. But we do have a lot of men who still, after a prostate treatment, deal with incontinence and deal with impotence and deal with a loss of libido, depending on which types of treatments they have. So I think it's not necessarily out of place to question why some of the treatments that we have historically abandoned have been abandoned when we have simply moved on to other treatments that are kind of giving some of the same side effects. That would be one thing to do with historical material. But another thing to do with it would be to apply some sort of theoretical lens to the questions and conversations that are being talked about in the archive material. And here, for me, it was really, really easy to look at the material historically about how the prostate was being treated and see quite clearly that there were very few patient voices in that material. There was very few discussions about what the patient wanted and what the patient was happy with or unhappy with afterwards. Some of it did occur around the castration, but much of it was there. The patient was very, very absent completely. And as a person who's worked a lot with science and technology studies and theories about knowledge, I thought it was really clear that there was still in much of this material a perspective that adapted and adopted the biomedical gaze as an external view from nowhere, now sometimes, as you can see, modeled by this surgical theater, or in anatomy books, these sketches with the bodies cut in half that just showed the body as it was. I have a picture of a gynecological exam from the early 1800s on here too, because I want to show how a person could think through this in a way that incorporated what we have learned to call the epistemological critique within studies of women's health. Here we have a picture of how some knowledge is being made in a very embodied and yet still very distanced way. You'll see the gaze is nowhere near the patient's gaze of the gynecologist, doctor. This would be before gynecology existed as a field. But there's no conversation with the patient. There's just an examination going on. And I felt like this was maybe a conversation that kind of needed to be made around prostate health, at least historically, and actually quite a bit today as well. I didn't feel that we were encountering an awful lot of material that had anywhere in its background a concern for the man's knowledge of his body or the man's knowledge of his prostate. And I thought that given that we have within women's health a long conversation that has forced the medical community to ask, what do we want to do with our bodies? Who gets to decide what a healthy body is? What care is good care? All of these lessons from women's health activism could open up some really interesting conversations about prostate health as well. And of course, there is the conundrum of women's health activism, which is groups of patients, whether they identify as women or not, want more and better care, but they don't want to be over-cared for. We don't want medicalization happening as well. And where do you find that balance? And this is a balance that I feel comes into conversation around the use of the PSA test and PSA screening in a way that we could pull apart and nuance more if we were able to rely on some of the theoretical conversations we've had in women's health before. For example, if we ask the question about what is the prostate today, if you look at your medical diagnostic guidelines, you'll find that an awful lot of ways of knowing how the prostate is, how healthy it is today, have to do with knowing how urination is happening, what sort of urination patterns are occurring for the person with the prostate. There's the bothersome index, the frequency volume chart, there's lots of flow rate recordings, there's machines to do it, there's inscription devices, but then there's also the patient's understanding of his urination practices. How bothersome are they? How many times a night is this person waking up? How often do they have to find the bathroom when they're out doing it? When they're out in the town, for example. All of these things are ways of knowing the prostate. And yet very few of them actually measure the prostate in any way, shape, or form. They measure the effect of a potentially diseased prostate on the body and the body's practices. I'm going to skip this slide because because it's really way too long. But it is about another question we found in our work, which was around the whole conversation of prostatitis And the idea that prostatitis is actually a disease versus the conversations happening in lots of urology organizations right now asking people to stop using prostatitis as a diagnosis because it's really just an umbrella term for a lot of different conversations or a lot of different presentations that we really can't find a sole cure for. That in itself, I think, is really interesting. But what we ended up finding in our work, which is contextualized in Sweden, that has a different type of healthcare structure than what you guys have here in the States, but I suspect there might be something similar going on here. What we found was that patients who present to their general practitioner with pain or discomfort in this area and urination issues would be quickly directed to a specialist. If that patient had in their body a prostate, that patient would be directed to a urologist. If that patient had a uterus, they would be directed to gynecologists or obstetricians, like women's clinics. They would encounter incredibly different types of care for the same symptoms in these two places. In the one, they would be diagnosed often with prostatitis and prescribed antibiotics. And 15% of the time that would work, some in the other times it wouldn't. If they were that body was directed into the gynecology or women's health clinics, they would often be seen by urotherapists who work on the pelvic floor muscles and work with strengthening or dealing with tensions in the pelvic floor. These are two really different types of ways of treating the same problem. And what I think we find in this type of treatment is that we see how bodies with a particular set of symptoms are produced by our understandings of the binary sex paradigm that have created a system of medical specialists that are either for male bodies or female bodies. And if we had a different paradigm, we would have bodies being treated very differently in these two. And now I'm looking at the clock and I'm thinking, I don't have time to tell you the joke about the DRE. But you've probably heard lots of them. And one of the things that we really made a point of when we were thinking about the digital rectal exam was that jokes appeared everywhere about it, probably because there's a lot of discomfort, not just physical, but emotional or psychological discomfort with the DRE and the exam. And we had an anthropologist follow the students out to follow medical students as they learned the DRE, and she also followed the same medical students as they learned the bimanual pelvic exam on bodies with uteruses. And what she saw was that there was a very different production of a patient subject in both of these. In the one case, they learned how to do an exam on a body that was being expected to take it like a man, just get it over and get it done with. In the other case, they found the production of a subject, patient subject, that was presented as a very amazing body that could do really, really incredible things, make a baby, but which was also potentially a very sensitive subject who maybe had a lot of different things in their emotional baggage with them into the examination room. And these two different patient subjectivities were reinforced by the way that the exams were given. There's more on that in the book. We also talk about the PSA, and here too, about the way the PSA screening debate in Sweden is really a debate that talks about blood levels, or prostate-specific antigen levels in the blood, but doesn't talk about the production of a very vulnerable patient subjectivity as well, and the production of fear and the production of a sudden awareness of one's mortality, and how all of those need to be engaged in conversations about the screening recommendations that the Swedish government will or will not choose to take. And then we had a lot of conversations about how you see and know the prostate, and how the technologies for visualizing the prostate are working in very close conversation with the types of treatments that we develop and evolve to do something with the prostate. So we sort of came to the conclusion that there were lots of different ways to know the body, or know the prostate. We could know the prostate through its effect on the body, like urination. We could know the prostate through its effect on the systems of the body, the PSA in the blood, which is often taken from the elbow or sometimes the finger. You could know the prostate through feeling it, which is almost one of the few times when you almost feel the prostate, but not quite anyways, because there's also the bowel membrane between it. We could know the prostate through visualization tools. We could know the prostate as it behaves in the body in comparison to other bodies, for example, with the woman's body and the removal of the ovaries. All of these different ways of knowing the prostate produce a very different type of prostate, which is why when we ended up writing the book, I talked about calling it a biography, because just like a biography takes in ways of knowing a person from many different voices, many different people who knew the person. Here too, we thought it was really, really important to show that the prostate is known in many different ways and becomes something very different in all of that. But the most important thing, I think, was that we also found that the absent prostate was often the most known prostate. So once the prostate was removed from the body, it was then that the bodies with that prostate ended up having problems. It was after some sort of medical treatment, oftentimes surgery, when the patients would develop incontinence or impotence, when all of these problems of the prostate became really, really apparent. So the absent prostate was the one that created a lot of problems. However, when we saw this, we ended up really having to ask, whose prostate are we talking about? Because in the absent prostate conversations, we saw that prostate problems are experienced very differently by different men. And I'm actually working in the field of gender studies, a field that has been dealing with the concept of intersectionality for like 30 years. So you would think that somebody who has this background, who has always, during my professional career, been reminded continuously that women is a completely useless category because there are so many different types of women with so many different positionalities. Why on earth would I think that the category men would be equally useful? It's not. It's equally unuseful. There are so many different types of men who are positioned differently by society's different power structures and who need a very personal type of prostate care. I would say that the usual suspects are really important to consider: race, class, geographical location, social network, access to care. But that there are other types of things we also have to consider when dealing with men and asking them what kind of prostate care and what kind of results of their prostate care they think are going to be most important. And merely that one twist in asking the person what kind of care they want is a really, really big step. But finally, I also want to talk about how these men are affected differently, but it's maybe not only their responsibility. I think it's so easy for us who work with questions around the body to think about the body as the container of those problems and the person whose body it is as the person who is responsible for accessing treatment, and that the body there is the normal target for treatment. However, when I was talking with men who had had prostate issues, it became really clear to me that many of their issues afterwards, especially around incontinence, but also around impotence, and also around just feelings about social isolation, were issues that could be addressed socially as well as medically. That we as a collective have a responsibility to see that we have structures around in our public spaces that help all bodies. So for example, we could make sure that we have sufficient public toilets available, but that those public toilets have stalls with doors for men who need to deal with incontinence pads or catheters, and that there are places to throw incontinence pads and catheters away, even in the men's bathrooms. Just making sure that we have the type of infrastructure necessary for these bodies and the activities those bodies do would enable these men to be less socially isolated because of their current situation. So taking a page again from the women's health activism, saying it's not only for the individual woman to take responsibility for their health, we also have to think in terms of social structures for it as well. Right, so I think I will pause there, and we have 10 minutes left of the talk if there are any questions.
Gideon Manning again. So I guess I have two questions, if that's okay. So the first question is, about the identification of the prostate and how it, as you pointed out, I mean, there are different criteria for identifying it depending on sort of where you're coming from, where you're approaching it. So I want to ask about one that I'm not sure how to fit onto the list. And then I had a question just about what are there instances of questions about health and disease and bodies where for particular organs, maybe the kind of study you're suggesting actually doesn't fit so well? Are there any that come to mind? And what does that tell us about those particular organs or the sort of issues that surround it? So here's my harder question, I guess, right? So in the 2nd century AD, one of the earliest accounts of surgery with really exacting detail that survives in the West comes from Celsus, and it has to do with lithotomy. So he describes a procedure for how you remove a bladder stone that involves a transperineal incision, and sort of you go in that way. But he's quite explicit that that technique is only appropriate for people, men, boys of a certain age. And once they reach that age, beyond that, you can't actually go that way. And you can't because of the prostate. So, but that's not one of the 5. It's a kind of, you come to know the prostate because of the obstacle it presents to a kind of surgical intervention. So that's my hard question. And then my other one is, are there instances or organs where you don't know that this kind of approach or research strategy might apply so well? Thank you.
Yeah, thank you. Thank you for that example. And I think it's just one I want to add to that list. That's fantastic. In a sense, it reminds me of the fact that there are lots of people who talk about knowing their prostate when it itself becomes an obstacle to processes like urination. So it's just in the way. But I am not aware of that one, and I'm going to get the reference from you after the talk. Yeah, thank you. The second question, if I think that there are organs that could not benefit from this type of approach. I may not be the most objective person to ask for this, but I'm going to say no. And I say that because I think when I first proposed doing the prostate this way, it was met with a lot of, what, why? No, it's just the prostate. It gets cancer and it's terrible, and then you're done. But I think actually thinking through it from these different perspectives gave a lot of insight to how our body is being produced in different conversations. And I say that I didn't include this here because it wasn't done particularly rigorously, but during the conversations that I had around this project during its long duration, I ended up speaking to a few people who work in acupuncture. And I was asking them about how they used acupuncture to treat prostate issues. And these were Swedish, but they were working with Chinese traditional medicine as their field. And they were really, really kind in listening to me and taking my question over and over and over again and trying to avoid answering it. And finally, after about 15 minutes, one of them was like, "Ericka, we get it. We know what you're talking about. We know what the prostate is. We don't treat the prostate because we don't treat an organ. We treat systems. We treat systems that are oftentimes if we overlap them onto Western medical understandings of the body, systems that contain different types of glands, but not necessarily the whole thing, and also have to do with the production of particular practices in the body rather than being a discrete gland that you could cut away during a dissection, which has been how we know the body. So I think thinking through how we know the body, if it's practice or if it's our own experiences of practice or if it's like by dissecting a body and trying to tease at those practices of knowing the body is important for all of them. So yeah, thank you.
Thank you so much for this interesting talk. I think you touched on this a little bit, but I was wondering if you could discuss a bit more the ways that ideas about masculinity and what it means to be a man kind of intersected with maybe knowing the prostate, I mean, including the absence of discussions of prostate or prostate care, and being a historian, kind of if your team kind of notice any changes in that over time, like changing ideas of masculinity, manhood in relation to discussions of the prostate and people's willingness to broach the subject sexually.
Yeah, thank you. What we noticed was that at the end of the 1800s and into the beginning of the 1900s, in Western medicine, the prostate was very closely associated with sexuality, and sexuality in a very moral framework. So it wasn't quite clear which direction the causality was going, but it was pretty clear in the medical literature that there was the assumption that the prostate, in its normal healthy form or in its enlarged form, was related to what type of sexual practices the person was engaged in. Homosexuality or men who have sex with men was not part of that conversation at all, but rather the moral issues became part of, is this person having sex within marriage and in a sufficiently but not too frequent manner? Or is this person having far too much sex, maybe with people outside of marriage or maybe with a much younger wife, in which case there was a moral tone put to it. Now, if they were having sex with a younger wife or way too much sex, if that caused the prostate to become enlarged, or if it was because the prostate was enlarged that they were now misbehaving this way, and it was like really morally, most of it was really moral. This conversation, that wasn't clear, but the enlarged prostate and an over-sexuality was often really closely associated with each other. However, at the time, now this was before antibiotics existed, there was widespread gonorrhea, and if you got gonorrhea when you were young, by the time you had an enlarged prostate, you probably also had a latent gonorrhea infection for many, many years, possibly decades, and probably had scarring on the inside of your urethra, which would cause the same types of problems that an enlarged prostate could cause. That is, it's difficult to urinate. So there was really, really little clarity. In fact, there was still an ongoing conversation about whether or not gonorrhea and prostate issues were related, or if they were completely different, separate things. But there was a large body of thinkers who suspected that sowing your oats in a fairly wild manner as a youth could produce prostate problems as you aged, though it might be because of the gonorrhea. So you see, there was not clarity, but there was a lot of conversation about sexuality. So that said, that's historical. We no longer think that prostate problems and enlarged prostate is because of gonorrhea, mostly because we get it treated these days. But I would argue that understandings about the prostate are still colored by understandings about what it means to be a person who has undergone prostate treatments and maybe is not able to perform their understandings of what masculinity is in the same way as they did prior to the treatments. That said, what we also found was that the understandings that they met from sexologists and sexology experts, when they even met them in Sweden, now this was done in Sweden, were oftentimes focused around the idea that a man post-operation, post-prostatectomy, would want to perform penetrative vaginal sex. But when we asked questions about it, it turns out actually lots of men do lots of other things than just that. And so conversations and treatments that are only directed towards being able to recreate this understanding of sex were, one, not always successful, and two, not always the thing that the man wanted to do anyway. So trying to open up again and see that sexuality and sexual practices are oftentimes not necessarily overlapping, that you can have sexual practices without identities assigned to them, but also opening up for the idea that different types of sexual practices happen all over the place, and we need to talk with the men about what they want, was also a really interesting, surprisingly surprising, but we tried to open up for that.
I have a question. I was thinking about what you kind of passed over the jokes. There are there's such discomfort, and I'm a pediatrician. My husband's an internist. I hear a lot of his stories about the patients he takes care of. But I just am curious, in your setting in Sweden, where you have this, I'm very jealous of this incredible humanities center that is interdisciplinary, and there's medical and humanities people together. Has your work been recognized and implemented or thought about in the clinical space? Do you feel like there's a way for getting this beautiful work to the place it needs to be, so that people maybe can begin to be more comfortable about talking about the issues they're having and how to, sort of just reform the care of people with prostates?
I wish I could say yes. Yeah, I wish I could say yes. And maybe I can say yes a little bit. So I think it really helped that we had the sexologist with us, right? I mean, she's still working at a urology clinic. She's still working and meeting patients, and she's talking about this. And she has actually co-authored with a urologist a guidebook for patients in Swedish, where some of these ideas come in. So I'm going to say yes. But I'm going to say yes smallly, because we've also been out and presented at urology conferences, and I think we're like the weird but before lunch talk that is kind of like quasi entertainment. So I don't know that it's really having huge impacts yet. But I think maybe that's a lesson for me to learn as well, that, okay, I didn't invite any doctors into this project. Maybe I should have, because maybe that's the in to getting it into their practices. Yeah.
Dr. Schaaf took the words right out of my mouth. That was the question I was going to ask. So who again did you get the grant from?
Right, so I got the grant from the Swedish Science Council, which is like the big, it's kind of like, I think it's called the NSF here, it's the big national funding agency.
Is there any way that they could get involved with your government to have it, since you have the socialized healthcare there?
Right, so
Just to further that, because I think it's very important. This subject touches me in a way that it might not others. My father suffered from prostate cancer, lived through that, but it ended up with kidney and pancreas cancer, and I'm convinced that it came from his prostate cancer that his urologist did not pay attention to after he had his radiation and whatnot.
Yeah, I think there's a limited role that the Swedish Science Council could do. But one thing that we have done, and this is maybe something we can talk about more after the seminar as well, is that we, especially with the Center for Medical Humanities and Bioethics, are organizing a series of what we call scientific salons, where we invite representatives from different bodies that we think should be listening to this sort of stuff to come and talk, so that they're invited to come and speak. And then we have medical humanities people who also speak in panels. And then we give them like some red wine and some cheese, and we have a conversation. And we sometimes invite our government, like ministers from the government or bureaucrats from the different agencies, because who doesn't want to get invited to, have some red wine and cheese in a nice place up in Stockholm? And we make them sit and listen, and we make them have conversations, we make them introduce each other, and we try to shift the frame of the conversation that way with some of these insights. It's not always useful, but it isn't necessarily unuseful either. We feel like that's one way of trying to get that conversation out. So, okay, we've written a book. We've got lots of articles. They're all open access. We're hoping, I know that there's a urologist up in Berkeley who's citing one of our studies with the gay men and and the sexuality stuff. So I think it's getting out there, and this stuff takes time, and that will all work. And the scientific publication is what we do. But I think we can do so much more. So I think these scientific salons are really important. Being able to come and talk with medical students here, also really important. Just trying to spread it in every way we can, I think is what we try to do. Thanks.
I think we're at time, but I want to thank you so much for a wonderful presentation. And I want to thank our colleagues at Cedars for this wonderful collaboration, hopefully the first of many. And CME credit available to physicians who want to claim it. And Dr. Johnson will be available to sign books out in the foyer outside of the lecture hall. So thank you.
Thank you.